you ever wondered why you can never hear a patient with pneumonia passing urine? Well, because in pneumonia, P is silent. Hi everybody, it's Ryan here. Hope you and your family are well. Today we're discussing a very pertinent, very common topic in medicine, and that's pneumonia. All right, this is an overview of the talk. We're going to be discussing a clinical case as usual. Then we're going to be delving into pneumonia, looking at the different types and how we stratify the different types. Typical versus atypical, community-acquired versus nosocomial versus ventilator-associated versus aspiration-associated versus healthcare-associated. Then we're going to look at the presentations and looking at how we grade the severity. We're going to delve into complications, investigations, and treatment, and of course end off with scripture. God bless you. Thanks for joining me. Alrighty, so let's get stuck into this. We've got a 55-year-old man who presents to his primary care physician with a 2-day history of cough and fever. His cough is productive of thick, dark green sputum. Yucky. His past medical history is significant for hypercholesterolemia, treated with rosuvastatin, the kingpin, the Rolls Royce of statins, rosuvastatin, Crestor. He does not smoke cigarettes and is generally quite healthy, exercising several times weekly. He has no ill contacts. Cannot recall the last time he was treated with any antibiotics. On presentation, his vitals are pyrexial at a temperature of 8.9. Blood pressure is okay, 132/78. Heart rate of 87 beats per minute. He is not tachycardic. Respiratory rate of 22 breaths per minute. So he is slightly distressed with a SATs of 95% in room air. Crackles are present at the right lung base, as is agophony. Chest X-ray demonstrates segmental consolidation of the right lower lobe with our beloved air bronchograms. What's the appropriate approach to ongoing care of this patient? Is it A, obtain a sputum culture and await results prior to initiating treatment? Is it B, perform a chest CT to rule out post-obstructive pneumonia? C, refer to the ED for admission and treatment with IV antibiotics? Is it D, treat with amoxicillin? Or E, treat with moxifloxacin? Well, guys, what really is consolidation? It is defined as inflammation in the lung parenchyma characterized by accumulation of secretions and inflammatory cells in the alveoli. When we speak to consolidation, we speak to lobar pneumonia, and this is exactly what we see here. A beautiful, homogeneous opacification in that right upper and middle lobe, right? So you got an air bronchogram there as well. This speaks to consolidation. A beautiful lobar pneumonia. Okay, the differential diagnosis for that can be consolidation, bronchial carcinoma, TB. We're focusing mainly on consolidation. Guys, how do we classify pneumonia? So, community-acquired pneumonia classically is infection acquired from the community, like the name implies, community-acquired pneumonia, CAP, and has absence of any of the below risk factors. We'll talk about that. Hospital-acquired pneumonia, HAP, right, is nosocomial infection that appears more than 48 hours after presentation, more than 48 hours after admission to hospital. VAP, which is ventilator-associated pneumonia, presents 48 to 72 hours after endotracheal intubation. Then we've got this entity called HCAP, healthcare-associated pneumonia, which is diagnosed after the patient is hospitalized for 48 hours and within the last 90 days. And the patient did receive intravenous therapy, wound care, or chemotherapy within the last 30 days. The patient resides in a nursing home and or was dialyzed within the last 30 days. Right? Aspiration pneumonia happens in patients who have aspirated secretions, right? So they have diminished level of consciousness, they may have dysphagia or some degree of neuromuscular disease, they have diminished host defense resulting in significant aspiration and infection. So you're telling me, Ryan, we got a whole lot of alphabet soup, hodgepodge, CAP, HAP, VAP, HCAP, and aspiration. What about immunosuppression as well? Yes, you do have pneumonia in the immunosuppressed, which we'll talk about, right? Here's a beautiful diagram from Jorge Muniz at MedComic.com. Thank you so much. And here we can look at pneumonia. So typical community-acquired pneumonia refers to acute infection of lung parenchyma acquired outside of the hospital or less than 48 hours within admission. And the most common cause of typical CAP is strep pneumo. There we are, strep pneumo. Typical symptoms: fever, cough, sputum production, rigors, pruritic chest pain, dyspnea, tachycardia, bronchial breath sounds and crackles and auscultation. We also get agophony, where E sounds like A, E sounds like A. You also have whispering, soliloquy, tactile phlegmatis, and vocal resonance. Vocal resonance are increased. You ask the patient to say 99. It sounds like 99. I'm sure we're all familiar with these. Okay, guys, what are the causes of community-acquired pneumonia? So the typical organisms we know to be Streptococcus pneumoniae in 50%, Klebsiella pneumoniae, Haemophilus influenza, Staphylococcus aureus, Moraxella catarrhalis. Atypical organisms behind community-acquired pneumonia include Mycoplasma pneumonia, Legionella pneumophila, Chlamydia psittaci, and Coxiella benneti. Others can be viral pneumonia, especially COVID. Don't forget that in your differential. Influenza, parainfluenza, measles, respiratory syncytial virus, varicella, cytomegalovirus, as well as actinomyces israelii as well. The different pathological stages of community-acquired pneumonia, so there's 4 stages, right? And so we've got the stage of congestion, which persists for 1 to 2 days initially. Then we've got the stage of red hepatization. And if we look at the pathological specimen of a lung, which is in this stage, of pathology, it looks red and solid just like the liver. Hence the term red hepatization. This persists for 2 to 4 days after congestion. Then we have the stage of gray hepatization, which persists for 4 to 8 days. And then the stage of resolution, which is 8 to 9 days or more. So if you're going to categorize pneumonia, this is a handy algorithm that we developed. You can catch this on a previous video of mine on pneumonia. So we stratified the 32 causes of pneumonia into either community and hospital acquired. And in community acquired, we have typical versus atypical. So typical, the usual folks, strep pneumonia, Haemophilus influenza, Moraxella catarrhalis. The atypical flavor includes viral, Mycoplasma pneumonia, Legionella pneumophila, Chlamydia pneumonia, Coxiella benneti, Francisella tularensis. The endemic flavor of the community-acquired pneumonia includes TB, and more TB. Remember, us in South Africa, in sub-Saharan Africa, it is endemic for tuberculosis, right? Coccidioidomycosis is not so common in our setting. Histoplasmosis, blastomycosis, cryptococcosis. Aspiration pneumonia can be acquired both in the hospital and in the community. People who have diminished level of consciousness, people who have some degree of neuromuscular dysfunction and they have problem with swallowing, so they aspirate their secretions. People who are inebriated, right? And common etiologies behind aspiration pneumonia are anaerobic infections, Streptococcus gram-negative bacilli, and Staph aureus. And the hospital-acquired pneumonia happens after 48 hours post-admission to hospital, and these include the enteric gram-negative bacilli, Haemophilus influenza, Strep pneumonia, Staph aureus, Pseudomonas aeruginosa, Acinetobacter baumannii. Ventilator-associated pneumonia happens more than 48 hours post-intratracheal intubation, and then we talk about enteric gram-negative bacilli, Staph aureus, Pseudomonas aeruginosa, and Acinetobacter baumannii. Okay, guys, what are the presentations of community-acquired pneumonia? What do these patients complain of, or what do they present with? So fever may be accompanied by chills and rigors, cough, which is initially short, painful, and dry, later on becoming productive. So they expectorate secretions. A rusty sputum is said to be due to strep pneumo. If you get recurrent jelly sputum, said to speak directly to Klebs pneumonia. The patient may be dyspneic, may have hemoptysis, may have pleuritic chest pain, and the chest pain may actually radiate to the shoulder and the abdomen. Other features include anorexia, nausea, and vomiting. Then, of course, you get a whole host of extrapulmonary features, and then we have myalgia, arthralgia, malaise, which is common with Legionella and Mycoplasma, the atypical flavor of pneumonia, of CAP. Then myocarditis and pericarditis, common in Mycoplasma pneumoniae, also in COVID. Headache, meningoencephalitis, and other neurological abnormalities common in Legionella pneumonia. Abdominal pain, diarrhea, vomiting, hepatitis, complicates Legionella pneumonia. Labial herpes simplex deactivation, common in pneumococcal pneumonia, and skin rashes such as the erythema multiforme. Erythema nodosum sometimes happens in the setting of Mycoplasma pneumoniae. So this is a beautiful diagram taken from Pathophysiology of Disease. Thank you so much, guys. It outlines the normal host pulmonary defense mechanisms, right? So we know that we have the beautiful mucociliary escalator, right, which lines the epithelium of our conducting airways. Here we have a beautiful goblet cell which elaborates mucus, and the claim to fame of mucus is that it traps all your particulate matter, which makes it into the airways, right? And then the beating of the cilia forces the mucus together with this particulate matter up and out, right? Then, at the level of the alveolus, if you have some antigenic foreign matter which makes it down to the alveolus, we have our beautiful alveolar macrophages which engulf or phagocytose these particles, and they then present this to an antigen. So this is an antigen-presenting cell which presents it to the lymphocytes. The neutrophils do the same, right? And through the process of opsonization, they are presented to the lymphocytes, and the lymphocytes, okay, mainly are located in the lymph nodes, right? They then produce antibodies, right? If it's a B lymphocyte, the plasma cell produces antibodies. If it's a T lymphocyte, their function is to prime other immune cells to recognize these foreign antigens and then instigate an inflammatory response. Alrighty. These are adventitious breath sounds, and the common ones that happen in pneumonia is your crackles, like snap, crackle, and pop, right? Uh, and in asthma and COPD, you're going to hear wheezes. Rhonchi suggests, secretions in the larger airways. Okay, what are the risk factors for pneumonia, everybody? Well, I'm glad you asked. If your age is below 16 or above 65, so extremes of age, the kiddies and the geriatrics. Comorbidities like HIV infection, diabetes mellitus, chronic kidney disease, malnutrition, all of these cause some degree of immunoparesis. Upper respiratory tract infections, recent influenza infection, or other viral respiratory infections, right? Pre-existing lung disease, like patients who have cystic fibrosis, bronchiectasis, chronic obstructive pulmonary disease, or an obstructive lesion in the way of bronchial carcinoma, inhaled foreign body, inhalation from esophageal obstruction, lifestyle, cigarette smoking, excessive alcohol, IV drug use, iatrogenic issues like immunosuppressant therapy in the way of prolonged use of steroids, cytotoxic drugs. Others, of course, hospitalized ill patients and indoor air pollution. Alrighty, what are some of the complications of pneumonia? Well, it can be divided into pulmonary and extrapulmonary. Pulmonary include things like lung abscess, pleurisy, pleural effusion, empyema, thoracic, pneumothorax, especially Staph aureus, and pneumocystis jirovecii. Don't forget about that one. Fibrosis of the lung, collapse, acute respiratory distress syndrome, ARDS. We'll be talking about this in our next video. Delayed or slow resolution. Then cardiovascular sequelae includes pericarditis, myocarditis, endocarditis, arrhythmia, peripheral circulatory failure, overwhelming sepsis. Neurological can be in the form of meningism or meningoencephalitis, musculoskeletal in the way of septic arthritis. Iatrogenic complications, especially with immunosuppressant therapy, we talk about prolonged use of steroids and cytotoxic drugs. Gastrointestinal complication can be something we call meteorism. This is not when a meteor comes from outer space and lands in your GIT. No. Here we're talking about gaseous distension of the stomach, intestine, and abdomen in the absence of ileus, which is a complication of septicemia coming from the pneumonia. Others include septicemia, renal failure, hepatitis, ectopic abscess formation by Staph aureus. Okay, commonly in our clinical setting, what are the causes of slow or delayed resolution of that pneumonia? It's just a stubborn infection. It just doesn't go away. So delayed resolution means that when the physical signs persist for more than 2 weeks and etiological features persist for more than 4 weeks after you have given the patient appropriate antibiotic therapy. And the causes are, number one, maybe it's an incorrect microbiological diagnosis. Right? Maybe you diagnosed the pneumonia, but the etiology is incorrect and you are treating with the inappropriate antibiotic. Or this could be a fungal, tubercular, or atypical pneumonia, in which case the antibiotics you gave is not working. Or it could be an improper antibiotic or insufficient dosage. Other possibilities is that the bronchus is obstructed and you have some kind of obstructive lesion there, like a bronchial carcinoma, adenoma, or a foreign body. Maybe there's a complication of the pneumonia present, like an empyema or atelectasis. We know that empyema is not going to resolve unless you put in an intercostal chest drain and give targeted antibiotic therapy. Maybe there's host factors at play, like an immunocompromised patient, for instance, HIV, or diabetes mellitus, or lymphoma, leukemia, multiple myeloma. All of these induce some degree of immunoparesis, okay? What are the causes of recurrent pneumonia, right? Which refers to 3 or more separate attacks, right? It could be due to bronchial obstruction in the way of a bronchial carcinoma or a foreign body. Could be due to lung disease like bronchiectasis or cystic fibrosis. Could be due to aspiration like achalasia, systemic sclerosis, or pharyngeal pouch. Once again, it could be due to the host factors coming into play, like an HIV positive patient who is yet to be diagnosed, diabetes, lymphoma, leukemia, multiple myeloma, immunoparesis. Remember the following points, everybody. The community-acquired pneumonia usually spreads by droplet infection, and most cases occur in someone who has been previously healthy. Physical signs of consolidation usually appear within 2 days and disappear within 2 weeks of the proper treatment. Radiological opacity appears within 12 to 18 hours and disappears within 4 weeks. So it takes long for those infiltrates for the consolidation to go away from the chest X-ray. If the radiological opacity persists after 8 weeks with treatment, it is called non-resolution. Okay, everybody. What grading system do we use to assess the severity of community-acquired pneumonia? Well, there's a couple we use. The Pneumonia Severity Index is one. The Curve 65 is the one that we commonly use locally. So Curve 65, for each a parameter we assign 1 point, okay? So confusion, you get 1 point, especially if the mini-mental state examination score is 8 or less, or the patient has new disorientation in time, place, or person. U means that the urea is above 7 millimoles per liter. R stands for respiratory rate being above 30 breaths per minute. B is blood pressure, with your systolic blood pressure less than 90 and diastolic less than 60 moles mercury. A is for age above 65. So a composite score of 0 or 1 probably means the patient can be managed as outpatient, with outpatient antibiotics. If you score 2 or more, that mandates hospitalization. A score of 3 or more, you do want to manage this patient in hospital and may require intensive care, especially if the score is 4 or 5. Another way of doing a severity in pneumonias by a scale we call the SMART COP. Yeah, you got a cop here who is very smart. Okay, so SMART COP basically stands for each of these parameters get 1 point assigned to them. So S stands for systolic blood pressure less than 90 moles mercury, you get 2 points for that, I beg your pardon. M means multilobar chest X-ray involvement, you get 1 point for that. A is the albumin, which is less than 3.5 grams per deciliter, but we use a different SI unit for that. R is the respiratory rate above 30 breaths per minute or above 25 per minute. In a patient less than 50 years, you get 1 point for that. T is tachycardia above 125, you get 1 point for that. C is confusion, must be new onset confusion, not in the patient who is known with dementia, right? O is for oxygen stats less than 90% or less than 93% if less than 50 years, or partial pressure of oxygen less than equal to 60 moles mercury or less than equal to 70 moles mercury if below 50 years of age, or a PF ratio of below 250, right? It's got 2 points for that, and P is a pH less than 7.35. Guys, severe community-acquired pneumonia is classified if you have a composite SMART COP score of 5 or more. If you're 5 to 6 points, you probably need ICU admission and ventilatory support. Above 7 points, very high risk of needing ventilatory support. Alrighty. So we mentioned this, right? What are the indications for referral of patients to ICU? So if you've got a curve score of 4 to 5 or a SMART COP score above 5, persistent hypoxia despite a high concentration of oxygen with a partial pressure of oxygen less than 8 kilopascals or less than 60 moles mercury. Progressive hypercapnia is an ominous sign of impending respiratory arrest, right? Severe acidosis on the back of CO2 retention, shock, and depressed consciousness. Okay, how do we treat community-acquired pneumonia? So sputum ideally should be sent for culture, sensitivity, acid fast, bacilli, gene expert before starting antibiotic. And the antibiotic you can start empirically with suspicion of the cause. So if you're dealing with mild community-acquired pneumonia, CUP score of 1 or below, you can treat as an outpatient with a beta-lactam like amoxicillin 500 milligrams 8 hourly, or augmentin or azithromycin, or augmentin erythromycin, or augmentin clarithromycin, all right? And the duration of the macrolide is usually 3 days. If Staph aureus is suspected, you want to give clarithromycin 500 milligrams BD orally or IV, usually orally, plus Fluclox, right? If Klebsiella is suspected, you can go Ciprobay 200 milligrams IV 12 hourly plus gentamicin, all right, or gentamicin plus ceftazidime. Duration of treatment is about 7 to 10 days, up to 14 days. If you suspect mycoplasma or Legionella, you can use clarithromycin or azithromycin, right? But if you're dealing with severe community-acquired pneumonia, then you want to opt for usually a beta-lactam with a macrolide, okay? So co-amoxiclav 1.2 grams 8 hourly for at least 5 days with azithromycin, for instance, 400 milligrams daily for 3 days. You can also offer ceftriaxone, especially if you have hepatic dysfunction. Augmentin is going to cause cholestasis, right? It may cause that as a side effect, so you rather want to opt for ceftriaxone, which is a cephalosporin, right? If Staph aureus is suspected, it's helpful to have Fluclox in there as well. So what are the criteria for discharge of a patient with pneumonia from the hospital? Well, to discharge, the patient should be clinically stable with none of the following signs. Ideally should not be pyrexial. Heart rate, these are the signs which mean that the patient is not suitable for discharge. If the temperature is above 37.8, if they're running a tachy of above 100, respiratory rate above 24, systolic blood pressure less than 90, inability to maintain oral intake, or an abnormal mental state. Okay, everybody, what is nosocomial pneumonia? Mention some causes. Nosocomial pneumonia basically means a new episode of pneumonia occurring at least 2 days after admission to hospital, so more than 48 hours, right? If it occurs within 4 to 5 days of admission, it's early onset and the organisms are quite similar to conventional community-acquired pneumonia. But if it occurs later than this, common organisms are gram-negative Enterobacteriaceae. The likes of E. coli, Klebs pneumonia, Pseudomonas aeruginosa are common. Watch out for Mr. SA, methicillin-resistant Staph aureus, as well as anaerobes, right? What are the predisposing factors for nosocomial pneumonia? There's a whole truckload of them. The elderly patients, those who are bedbound and unconscious, like those who had cerebrovascular accidents, post-operative cases, especially thoracic or abdominal surgery, malignancy, diabetes mellitus, use of steroids and cytotoxic drugs, and previous use of antibiotics, prolonged anesthesia, intubation, tracheostomy, IV cannula, right? Achalasia, dysphagia due to any cause of vomiting, bulbar or vocal cord palsy, nasogastric intubation, abdominal sepsis, infected emboli. How do we diagnose nosocomial pneumonia? So it has to do with the duration post-admission to hospital. After admission to hospital, associated with predisposing factors, if the patient develops cough with purulent sputum, fever associated with new radiological infiltrates, leukocytosis or leukopenia can swing either way, unexplained increase in oxygen requirements. How do we treat nosocomial pneumonia? So empiric antibiotic therapy should be started IV. If early onset happened within 48 hours post-admission, if no antibiotic was given, you can give a beta-lactam or you can give a cephalosporin. If antibiotic was given, you want to go second line, which is piperacillin, tazobactam, or the third generation cephalosporin like cefotaxime. If it's late onset HAP, which means it develops more than 48 hours post-admission, and you're thinking about gram-negative organisms, Staph aureus and anaerobes, you want to cover with a third generation cephalosporin like ceftriaxone with an aminoglycoside like gentamicin, or a monocyclic beta-lactam like aztreonam and fluclox. If you're suspecting methicillin-resistant Staph aureus, you want to opt for IV vancomycin. If possible, oral doxycycline, rifampicin, or linezolid may be given. If you're thinking about pseudomonas, you want to give IV ciprofloxacin or ceftazidime or dolapenem, carbapenem, or meropenem should be given, right? Don't hold back. Chest physio and oxygen, fluid, and nutritional support should be given. But it's important to do your blood cultures before you start the antibiotics and then tailor your antibiotic treatment as per the results, identification, and sensitivity based on your blood cultures, okay? Please note that aspiration pneumonia is also common in hospital and involves multiple organisms with anaerobes. Treatment is with coamoxiclav or cefuroxime plus metronidazole. Guys, what is bronchopneumonia? It is defined as a widespread, diffuse, patchy alveolar opacity associated with bronchial and bronchiolar inflammation, often affecting both lower lobes. In kids, it occurs as a complication of measles or whooping cough, and in the elderly, it presents a complication following bronchitis or influenza. What is typical pneumonia? It is characterized by high temperature with cough, pleuritic chest pain. Features of consolidation caused by strep, pneumo, Staph aureus are typical pathogens, right? Respiratory symptoms are more than constitutional symptoms, versus atypical pneumonia, where the constitutional symptoms are more prevalent than the respiratory symptoms. Here, the common culprits are mycoplasma, Legionella, Coxiella, chlamydia, right? Features are gradual onset of symptoms, dry cough, low-grade fever, constitutional symptoms, fewer findings in the chest. Please note that the term atypical pneumonia has largely been abandoned, as the clinical and radiological picture does not differ significantly from one organism to another. Mycoplasma pneumonia is more common in the young and rare among the elderly. Haemophilus influenza is more common among the elderly if underlying lung disease is present. Legionella pneumophila occurs in local outbreaks due to contaminated cooling towers in hotels, hospitals, and other industrial buildings. Staph aureus infection is more common following an episode of influenza. Just a quick note, guys, on mycoplasma pneumonia and Legionella. So mycoplasma is more common in kids and young adults, usually associated with, like we said, constitutional symptoms. Physical signs less marked. Episodes occur in a cycle every 3 to 4 years. How you investigate these patients? White cell count in the setting of mycoplasma pneumonia usually normal. Chest X-ray commonly shows a low lobe involvement, may show bilateral patchy consolidation. Cold agglutinins, very important. Cold agglutinins are positive in 50% of cases. You might want to do an antibody titer for mycoplasma pneumoniae. Other tests you may want to consider: complement fixation and hemagglutination. How do we diagnose and treat? Watch out for the extrapulmonary complications of mycoplasma pneumonia, which are legion, ranging from maculopapular skin rash to Stevens-Johnson to myompericarditis to hemolytic anemia, to meningoencephalitis and Guillain-Barré, to myalgia and arthralgia, hepatitis, and GI symptoms like vomiting and diarrhea. We treat with your macrolide antibiotics, essentially. How do we diagnose and treat Legionella pneumophila? Well, there's 3 patterns to Legionnaire's disease. One is an outbreak of infection, usually associated with a contaminated water supply or cooling system, or from stagnant water, usually in cistine or shower heads, coming from those sources. Sporadic cases where the source is largely unknown, usually common amongst the middle-aged and elderly, more so in smokers. Outbreaks may occur even among immunocompromised patients, example, those on corticosteroid therapy, those on diabetes and chronic kidney disease. Features, of course, more constitutional symptoms, less respiratory symptoms, sometimes nausea and vomiting, sometimes even renal failure and hematuria. Okay, investigations, white cell count will show lymphopenia without marked leukocytosis. Chest X-ray shows lobar or multilobar shadowing. Small pleural effusions may be present. Cavitation is rare. You often get hyponatremia. SIADH may be involved. Hypoalbuminemia, high transaminases. CK is also high, right? Direct immunofluorescence for Legionella in pleural fluid, sputum, or bronchial washings. Legionella serology is fourfold higher, and that's really the tip-off that you have. You can do a urine antigen test for Legionella. Urine MCS may show hematuria. How do you diagnose and treat Legionella? With your macrolides, essentially. And the prognosis has a 10% mortality, maybe up to 30% in the elderly. Everybody, how do we differentiate bacterial from viral pneumonia? So these are the telltale ways you do this, right? According to these 9 criteria. Onset in bacterial pneumonia is abrupt, and viral pneumonia is less abrupt. History of upper respiratory tract infection may be present with viral pneumonia but absent with bacterial. Systemic features, as we know, we get a high-grade fever with chills and rigors in bacterial, but in viral it's usually low-grade fever with more constitutional symptoms. The cough in bacterial pneumonia is initially dry, later rusty sputum or puddlant sputum, but in viral pneumonia it's usually dry. And we note that the extrapulmonary features are more prevalent. Allergic chest pain is common in bacterial, not so much in viral. Physical signs of consolidation well marked in bacterial, minimal with viral. Blood count is normal, or you may have leukopenia with viral, but with bacterial, the situation is leukocytosis. Chest X-ray in bacterial pneumonia will show lobar or segmental homogeneous opacity with air bronchograms, but in viral pneumonia, more mottling, more reticular pattern or patchy opacity or streaky infiltrates. Sputum culture in bacterial pneumonia organism is found, but not so with viral pneumonia. Guys, coming back to our clinical case, we had a 55-year-old male who came in with a 2-day history of cough and fever, thick greenish sputum, and he is being treated with rosuvastatin. He doesn't smoke, he exercises, he's generally healthy, his temperature is 38.9, blood pressure, heart rate are okay, slightly distressed, stats of 95% room air, crackles right lung base, agophony there, chest X-ray shows segmental consolidation of the right lower lobe with air bronchograms. What's the appropriate approach to this patient? Treat with amoxicillin, guys. So if you were to use the Curve 65 score, he doesn't score very highly. He can be managed as an outpatient. So in light of this, determining appropriate initial treatment for community-acquired pneumonia initially requires determining whether the severity of illness actually warrants admission to hospital. Clinical rules for determining potential severity of pneumonia: we can use the Pneumonia Severity Index, we can use the Curve 65, we can use the Smart Cop score. As per Curve 65, this patient meets none of these criteria, is not hypoxic, and is not in a high risk group for complications of CAP as we discussed. Therefore, he can be safely treated as an outpatient without further diagnostic workup, as the history, physical exam, and chest X-ray are consistent with the diagnosis of community-acquired pneumonia. My friends, let's just talk about what the Bible has to tell us about the subject of anger. Proverbs 16 verse 32 says, "He who is slow to anger is better than the mighty, and he who rules his spirit than he who takes a city." Proverbs 9:11 says, "The discretion of a man makes him slow to anger, and his glory is to overlook a transgression." The book of James admonishes us to be quick to listen, slow to speak, and slow to become angry. One of the fruit of the Holy Spirit is self-control. And I pray that upon you and your life that we will be able to control our speech, not become easily angered, not become easily offended, but to show grace, love, and patience. God bless you, everybody. Here are my references. I'll see you soon. We're going to be chatting about acute respiratory distress syndrome in the next video. Looking forward to seeing you then. God bless you. Take care. By the way, you can catch me on Facebook. My channel, or my Facebook page is entitled Algorithms and Mnemonics in Internal Medicine. You can also catch me on Instagram as well. God bless you.